Welcome this afternoon. I'm Dr. Hal Danzer, one of the co-founders of Southern California Reproductive Center, and I'm here this afternoon with Dr. Susan Maxwell, talking about pursuing LGBTQ plus conception with confidence. So it's a lot of ground to cover. There's a lot of variations on the theme and how we help individuals and couples achieve a pregnancy. Susan, do you want to talk about yourself?
Sure. So
Good.
I am board certified in both obstetrics and gynecology, as well as reproductive and endocrinology and infertility. I completed my training in OBGYN and REI at New York University School of Medicine. I've been at SCRC for just about a year since I moved to California. And I've been very happy to join the practice.
We've been very happy to have you.
Thank you.
I was here for the beginning of one of the co-founders for SCRC. That's 25 years ago, and we're certainly one of the most experienced IVF centers in the Southern California area. Again, with more than 25 years of experience. So we talk about the state-of-the-art embryology lab, and that's really the heart of a IVF center, to be able to create the highest quality embryos, which results in the very best in terms of pregnancy outcomes. We have a surgery center. Everything is located on one floor here in the Beverly Hills office. Santa Barbara office has also their own laboratory and surgery center. So it's kind of a one-stop place. We do have a Pasadena office now that monitors patients from that area. So what goes into the premier laboratory, and a lot of it has to do with experienced embryologist and an experienced lab director. We have almost a dozen embryologists. I mean, one of the largest IVF laboratories in Southern California. What it allows us to do is kind of double witness everything that goes on. So there's always a second embryologist that validates the name and the birth date for every sperm and egg and embryo before it's moved. We talk about flash freezing. That's the new technology for freezing eggs. But the thing that really stands out in terms of laboratory is the ability to fertilize an egg, to make an embryo, and grow it for 5 days to what they call the blastocyst stage. And that's very important because at that point, the blastocyst can be biopsied for genetic testing, or it can be frozen and transferred later. But the quality of the laboratory has a lot to do with being able to move those embryos from a 2-cell stage to a 100-cell stage. We also have what's known as an embryoscope. It's a time-lapse video analysis of how an embryo grows. And it's helpful for individuals or couples that have multiple embryos. It helps to rank the embryos. Embryos that usually go hopefully 2, 4, 8 cells in the very beginning. Some embryo go from 1 cell to 3 cells and 2 cells to 5 cells. And this asymmetric cleavage tells us that maybe just off a little bit genetically or structurally. And so you put those embryos that are asymmetric at the bottom of the grouping, and you transfer the best embryos first, which can improve pregnancy rates up to 15% in some studies. We'll go on to the next slide, but we're very proud of our laboratory and the very high quality work that they do. So today's discussion is family planning for everyone in the community. And Dr. Maxwell is going to start off, and I'll finish up towards the end.
Okay, great. Well, we wanted to do this topic because June is Pride Month. And as this celebration kicks off, we're shining a light on the fertility treatment options available to LGBTQIA couples, families, and individuals. We know that the path to parenthood is not always simple, and especially for those in the LGBTQ community. there can be many challenges. And so we are here to help you throughout your journey and provide many resources for the process. Next slide, please. Mhm. So for our patients who are in same-sex female relationships or couples, when we see them, our first step is really to assess the couple's reproductive goals. Does one individual, would they like to carry a pregnancy? Is this important to them? Yes or no? Is having a biologic relationship to the child something that's important? We go over how to obtain donor sperm, and sometimes patients have a known donor that they may be considering using. And then we discuss different treatment options with these patients, whether it's intrauterine insemination using donor sperm, or techniques such as reciprocal IVF, where one patient will undergo an IVF process, create embryos with their own eggs using donor sperm, and then that embryo can be transferred into the other female partner for her to carry the pregnancy. Next slide, please. For our same-sex male couples, we again get to know them really well, assess what their reproductive goals are and what's important to them for their family building. We then go into how to obtain donor eggs and take them through the process of finding a surrogate and screening that individual. Next slide, please. One of the advantages of our center is we have a full third-party program. So we're able to offer patients resources for obtaining donor eggs. We work with, we have our own agency. We also work with frozen egg banks. We can screen donors here, as well as screen gestational carriers. So we can take patients through the whole process of creating high quality embryos and then using them. Next slide. One of the first steps before selecting a sperm or egg donor for intended parents is for them to undergo genetic carrier screening. And this is a blood test that looks at 400 to about 450 conditions that either parent could carry. So these are single gene disorders. The patient themselves does not have this condition, but they may carry a mutation for it. And it's only an issue if that sperm or egg donor also is a carrier for that same condition. So we recommend that patients undergo this screening. We can do this blood test in our office. And then we recommend that couples select a sperm or egg donor who does not carry that condition if they are positive for something. And at SCRC, we offer genetic counseling to couples to help with selection of sperm or egg donors based on their own genetic carrier results. Okay, next slide. When selecting a sperm donor, there's two routes that patients go through to select a donor. The easiest way to obtain sperm is through one of the frozen donor sperm banks. It's important that the sperm bank is FDA approved and state licensed in order for us to use the sperm. These sperm donors undergo extensive screening for infectious diseases, genetic conditions, as we talked about, and psychological disorders. The frozen donor sperm undergoes a quarantine period of 6 months. And this means that at the time that it's frozen, that donor is tested for infectious diseases. And then the donor is tested 6 months later for those same diseases to make sure, to confirm the initial results. And the sperm is not released for use until that 6-month period. We recommend to our patients that they purchase IUI vials or intrauterine insemination vials, which there's approximately 10 million motile sperm in those samples, and that's suitable for IUI cycles or IVF cycles. 1 vial of sperm is needed per cycle of either IUI or IVF. And if couples are both wanting to use the same sperm donor, they may want to purchase more than 1 vial of that sperm. The other option is patients can use a known sperm donor, and we are able to provide comprehensive screening with FDA infectious disease testing, genetic testing of that donor, and psychological counseling. Next slide. For patients who are using egg donors, there are a few different options for obtaining donor eggs. One is to work with our Bright Expectations agency to find a match with a donor. So you would meet with the agency, let them know what type of donor characteristics you're looking for, and then they would try to find that individual for you. That person would then undergo a retrieval cycle at SCRC, and you would obtain all of the eggs from the cycle. So you typically get between 10 and 20 eggs, sometimes more, from a donor. And when you do a fresh donor cycle, multiple embryos are obtained, and there may be an opportunity to have more than 1 live birth from that cycle. The other option is to purchase frozen donor eggs from one of the approved egg banks. At SCRC, we work with some of the largest reputable egg banks in the country that have very proven thaw results. When you purchase a batch of frozen eggs, 6 to 8 eggs are typically obtained, and this results in 1 to 2 embryos on average. And each batch of eggs gives a chance at 1 live birth. Alternatively, patients may use a known egg donor, and again, we would be able to assist with screening that individual to make sure they're a suitable candidate. Next slide. For couples who are undergoing using a gestational carrier, there are many steps to the process. The first step is usually to create embryos, and then once embryos are created, the intended parents work with either an agency to match with a gestational carrier, or sometimes couples have a carrier, a known carrier they'd like to use, such as a friend or family member. We would then review the medical records of the gestational carrier to make sure she's a good candidate to carry. The gestational carrier would need a clearance letter from her OBGYN. And then she comes to our facility for medical screening. We do pre-pregnancy labs and infectious disease testing, a physical exam, and we assess the uterus to make sure that it is suitable to carry a pregnancy. And we do this primarily with a test called the saline infusion sonogram. The carrier and intended parents undergo psychological counseling, and then legal clearance is obtained to produce a contract for the gestational carrier. And then after all those steps are completed, we proceed with the frozen embryo transfer. Next slide. It's important to have legal counsel when either using a known donor or undergoing a gestational carrier arrangement. And your legal team can help to draft contracts, make sure there are no issues regarding parentage when the child is born. And for gestational carriers, they help to work through talking about compensation of the carrier and getting a birth certificate once the baby is born. Next slide. Okay, and now Dr. Danzer will discuss fertility treatments specifically that we do at our center.
So again, testing an egg donor. We talked about that may be one of the 2 female couples. It may be an anonymous donor. And we look at a blood test called AMH, which tells us about the egg reserve. And you can see on that diagram on the right, some people say it looks like a chocolate chip cookie, but those little dark areas are follicles, and each follicle, about 5 millimeters, has a microscopic egg. And the next slide will demonstrate how we stimulate the ovary to get multiple eggs that are mature. But in the beginning, we use prenatal vitamins, CoQ10, which is a supplement which may be associated with increased number of eggs. And also we always check vitamin D, which has been associated with higher pregnancy rates. The other part of the equation is the male testing. The source of sperm, whether it's from a known donor or an anonymous donor, they look at the volume, but the concentration is probably the most important thing, along with the motility. So they talk about 20 million sperm and about 50% motility. When you multiply that together, it's the total motile count, and that relates to very good fertilization rates. Even if sperm counts are low, a single sperm can be injected into the egg to compensate for that. Again, male supplements are available. Proxeed is a L-carnitine and antioxidant preparation, which may be helpful for men that have lower sperm counts or motility. CoQ10 again is used and may improve sperm density and quality. And we supplement with vitamin D if necessary. I think one of the things we know that's probably most important with sperm quality is the age of the donor. Obviously, for donors from sperm banks, most of them are in their early 20s. And that has implications. Sperm from men that are over 45 may have some increase in autism. So young donors, whether they're anonymous or a directed donor, you'd like to have some probably less than 30 years old. And again, once you have a sperm source, and we can do what they call intrauterine insemination, IUI, and it's used in concentrated sperm. We talked about the total motile count, so that they essentially do a swim up to select out the best swimmers. And that's important because probably 20% of the sperm are really strong enough to find the egg and actually burrow through the outer coating. So a preparation of an IUI takes about an hour. And again, once the ovulation time is identified, the partner comes in, or the frozen vial is warmed, and it's a very simple process, like a pap test. Very small catheter slides through the cervix, goes just a few inches to the center of the uterine cavity, and then the sperm or drops are deposited there, and then the sperm arrive at the end of the fallopian tube probably within a few hours. But again, timing of the release of the egg is also important with IUI, and we use at-home testing, the urine ovulation predictor test, or ultrasound. But identifying the time for insemination is really quite easy today with the technology available. Egg retrieval, or IVF, is the second part of the equation. And people say, well, why not start with IVF, or should I do IUI first? We know that with IUI, pregnancy rates can be the 8 or 10% range per cycle. You say, well, that's not very good, but the chance for anyone to get pregnant on average is about 25% per cycle. Couples just trying their own with intercourse. So many couples select IUI for at least 3 to 4 cycles. And then if they're not successful, you can move on to egg retrieval with an IVF. The benefit of IVF and doing stimulation with injections of follicle stimulator, you can retrieve 10 to 12, 15 to 20 eggs. So you have almost a full year of ovulations into 1 month. And once the eggs are in the laboratory, they can be injected with sperm, what we call ICSI. We'll go to the next slide. I'll come back. Here's the egg retrieval diagrammatically. It's a simple process, takes 15, 20 minutes, very light propofol anesthesia. Most people are able to leave after an hour and a half, and many take Tylenol. So it's a very safe, streamlined process. Complications are very uncommon. But once we have the egg, then we when we're able to inject the sperm into the egg, and you can see on the left slide, the needle is puncturing the egg, and the egg is really essentially jelly. You don't have to crack anything to place the sperm, and it doesn't damage the egg in any way, but it does sort of almost guarantee that you're going to have fertilization at higher rates. And once one sperm is placed in the egg, then the next day we look to see that we have a fertilized egg, which we call day one. And then you look again, and you can do this with the embryoscope, 2, 4, 8 cells. Our goal is a day 5, day 6, 100 cell, what they call blastocyst. And at that point, you can see from the diagram, the embryologist would take 2 or 3 placental cells, and then they freeze the embryo, and the cells are then sent out for genetic testing, which takes about a week. So that's why the embryos are frozen. And a blastocyst will freeze and thaw probably 98% of the time. It's rare that you would lose the embryo, which is of high quality. So the freezing technology is very good today, and that allows you to do the genetic testing, which takes about a week or 2 to get the results back. And then the normal embryos can be transferred about 6 weeks after the retrieval of the eggs. And this is a little video of what the beginning of life looks like once sperm is injected into the egg and it fertilizes. 2, 4, 8, now there's about 30 cells, 50 cells, 100 cells. And this is the blastocyst at the end, where we have placental cells and fetal cells at the top at the 12 o'clock area. And that's how we all got here, with the sperm and egg and genetically balanced embryo. And again, an embryo of that quality is frozen. Thaw rates are close to 98%. Fertilization, just like I say, is about 75%, and that's the reason for ICSI, just to guarantee good fertilization rates. About half of the fertilized eggs make it to the blastocyst stage in our laboratory, which is really a very excellent progression. And thaw rates are greater than 97%. But once you have a genetically tested embryo, then they talk about a 70% implantation rate and a full-term pregnancy rate, perhaps in the 65% range, with a very low miscarriage rate. So here you see just the diagram of frozen embryo transfer. Again, we monitor with ultrasound and blood test to determine where ovulation occurs. And many of the cycles now we're doing with natural ovulations. And once the ovulation occurs, the progesterone rises. And because it's a day 5 of embryo growth, we need 5 days of progesterone before we transfer. And again, the transfer is very much like a pap test. Very small catheter slides through the cervix into the uterine cavity, and the microscopic embryo is in one little drop of fluid, which we can see on the ultrasound, and release the embryo into the uterine cavity. High quality embryos, certainly genetically balanced embryos, probably implant 90% of the time. Implantation is relatively a simple part of the equation. 90% of it is the genetics of the embryo. So there's some promotions that are available and so on. But I think if we have questions now, we can start the question and answer, because that's the best part of the webinar, is answering the questions. Susan, do you want to pick up?
Yeah, I'm looking for the, oh, here, sorry, it was minimized. Let me see what is in the Q&A. Okay. How do you know if the embryo is ready to transfer into a gestational carrier? So first question. So all our embryos are created beforehand and frozen at the day 5 stage of development. And then the gestational carrier, her uterus is prepared using hormones. So we often give estrogen hormones to build up the lining of the uterus. And we check hormone levels and we do ultrasounds to see if the lining has developed normally. And if those results are normal, after about 2 weeks on estrogen, then we start progesterone supplementation. And then the gestational carrier will come to our center on the 6th day of progesterone administration, and we will thaw the embryo and transfer it. Mm-hmm. So the next question is, what if you are a same-sex male, but you don't? What if you're a male and you don't have a partner yet? Do you recommend preserving fertility by freezing sperm? And is this successful? What are your thoughts on this, Dr. Danzer? Mm-hmm.
Well, we were talking about that before, that
Mm-hmm.
certainly the studies and data suggest that sperm from younger men are better.
Mm-hmm.
Again, as you get into the 40s, there may be some issues with genetic predisposition to autism. Sperm can be frozen for 10, 15, 20 years. So I think any man in his 20s or 30s that's thinking about having a family through a egg donor process certainly would be fine to freeze sperm. Local sperm banks are probably the best source of for freezing sperm for extended periods of time. But I think that's a reasonable thing to do. Absolutely.
Mm-hmm. And frozen sperm does very well with IVF cycles. We get excellent fertilization rates compared to fresh sperm. Mm-hmm. Mm-hmm. Question is, do people sometimes use 2 vials for IUI, 2 vials of donor sperm for IUI? For my patients, I typically only have them use 1 vial and undergo 1 IUI procedure. Some people do a second IUI the following day, but it's not required for the treatment to be successful.
Yeah, in years past, we do 2 or 3 days in a row, but frozen sperm was $50 or $100, and now it's quite expensive. So with ultrasound and home ovulation predictor kits, we can time the IUI much better than in years past. Some couples that have been unsuccessful for 2 or 3 cycles may elect to do 2 days in a row. That's an option, but the expense is a consideration.
Mm-hmm. Yeah. The next question is, are there any hormones that people need to take for the IUI procedure? In the slides that we showed a medication called Avidrel. So it depends on the individual. If the patient is young, has good reserve, and is using donor sperm, oftentimes we'll start with a natural cycle, meaning we won't give any stimulating medications. We'll let the person develop a follicle on their own, but we do ultrasounds to monitor that follicle development. And when the follicle is the right size, we have the patient take an injection to cause ovulation. That is called the trigger shot, and there are a few different name brands of that. One is Avidrel. Another name for it is HCG, or human chorionic gonadotropin. So the trigger shot is helpful for inducing ovulation so that we can time the IUI procedure correctly. Mm-hmm. Okay. So the next question is, what would be the process for a single man to start the process? So the first step would be to schedule a consultation with one of the physicians in our office. And then we would start with some initial male testing. We'd have you get a semen analysis and talk to you about the donor egg process and create embryos first using donor eggs, and then proceed with the gestational carrier portion. Question is, how many IUIs do you recommend before moving to IVF? Dr. Danzer, do you want to answer that question?
I think it depends on the woman's age. You know, under 35, I think the guidelines are 3 to 4 IUI cycles, and some couples do 6. I think if you're over 35 or the late 30s, early 40s, I think you move much more quickly to the IVF process because you have a larger group of eggs to fertilize and then analyze for their genetics. At age 35, probably 65% of embryos are genetically balanced. At age 40, it's about 25%. So again, age is the big determinant of how quickly you move to the IVF process.
Are there any genetic tests in particular that you recommend for women who are wanting to use donor sperm and match their genetic profile? So at our clinic, we use a genetic testing company called Natera, and we do their Horizon panel, which has 445 conditions. There are other genetics companies that do similar patterns. But it is important to do a comprehensive or an expanded screen with a good number of genetic diseases that are tested, because the donors are also getting those expanded panels.
And I think most of the sperm banks, we see more and more of the donors are genetically screened for the expanded panels. And what 15% of all individuals are carriers of one single gene, but both have to be carriers for it to be an issue. As long as there's no combined single gene carrier status, then you can progress to the insemination cycle.
There's a question, what cryobanks does SCRC recommend? The largest cryobanks for obtaining donor sperm that I usually recommend are California Cryobank, Seattle Sperm Bank, and Fairfax Cryobank. It's possible to use another cryobank, but we do have to review and make sure that they are licensed correctly in order for us to accept the sperm.
But I think anyone's interested, they can Google, sperm donation and look to any of those large sperm banks. The sperm banks are heavily regulated by the FDA today. So the donors are screened in a very similar way for infectious disease. Transfer of viruses from donor sperm is almost unheard of today. So that's very safe. But these sperm banks, again, screen them for psychologically, family history, and by Googling any of the banks, they'll really outline how they select donors, and that's an easy first step. And then it's a matter of finding a good match from your lineage and your family history. Takes a while for most people to find a good match, but today, with the availability of hundreds of donors, thousands nationwide, you can usually find a pretty good match. Hair color, eye color, facial characteristics and a good family history.
Yeah. This next question asks, what does it mean to be CMV negative or positive from a sperm donor? This is a good question. Dr. Danzer was alluding to the chance of getting an infection or a virus from donor sperm is very low. CMV is a type of virus that a lot of the population has immunity to through prior exposure. And the donors are tested for this virus. It's one of the regulations, but what's tested is their immune markers. So they test to see if they have an active infection, if their immune profile shows an active infection or a past infection. And none of the donors will be accepted as a donor if they have an active infection with CMV. So what this is telling you when you see sperm donors, if they're CMV positive or negative, basically showing if they've had a past infection with CMV or not. For me, I allow my patients to use either CMV positive or negative sperm. I do not test my patients for CMV prior exposure. I don't know if you practice differently, Dr. Danzer, in terms of CMV.
Yeah, I think it's about a third of the population is CMV positive. CMV in terms of birth defects is really almost rare.
Mm-hmm. Question is, what's the process of sperm delivered to the clinic from a cryobank? Are there costs for receiving or storing the sperm ahead of an IUI? How long does it take to deliver sperm typically? So once someone has purchased donor sperm, then typically the sperm banks have us sign a form accepting the sperm, essentially. And then our cryobank team will reach out to the patient for them to sign consents to transport that sperm into our facility. The sperm bank on their end may charge a fee for shipment of the sperm. That's part of the cost of purchasing the sperm. It typically takes, I would say, about a week, sometimes less, for us to receive sperm once that shipment has been initiated from the sperm bank. If you are storing sperm, long-term at our facility, we do charge annual storage rates for that. Mm-hmm. Does insurance provide any coverage or assistance for single parents? Most fertility benefits are determined by employers, so it really depends on your individual insurance plans to see what's covered in terms of fertility for single parents. Mm-hmm. Let's see here. Are there any preparatory blood tests that one needs to do ahead of IUI treatment? So, when we see patients before IUI, we check their fertility hormones, like Dr. Danzer discussed, to see what their ovarian reserve is. We also do pre-pregnancy blood work. So we check infectious disease blood work. We look at immunization titers to see if patients need any vaccines before pregnancy. We'll do genetic screening tests if needed. And then we also check thyroid hormone. Mm. Okay. Question is, when should you prepare your body or detox before going through testing or moving forward with reciprocal IVF? What are your thoughts on that, Dr. Danz?
I'm sorry, I was just reading the next question.
Oh, can you see
I missed
that?
that one.
Yeah, they asked, how should you prepare your body before IVF, or should you detox in any way?
Depends on your lifestyle. I think the three things that are recommended to prepare yourself for pregnancy, certainly, or for any IVF process or fertility treatment. Number one is good nutrition. And we talk about Mediterranean diet. I don't think there's any specific food that's recommended, at least from the data we have available today. But a good diet, Mediterranean diet, moderate exercise. Taking a walk 45 minutes a day has tremendous health benefits and psychological benefits for everyone, whether you're trying to get pregnant or not, for the man and the woman. So those are two big things. And then the third thing is stress management. We've all have stress, and that's never going to go away, but we have to find ways of managing that. Again, the walk can be a big help. Certainly today we recommend mindfulness for everyone to manage their life, but certainly getting ready to have a family, you want to have some stress management skills. So those are, I think, the three most important things. And then obviously prenatal vitamins are recommended.
Okay. Well, I think, let's see. And it says, so the last question is, what about men? Is there any preparation before consultation? So for men, lifestyle changes can also be beneficial to sperm. I see men who drink excessively or use excessive marijuana, sometimes tobacco use, can have negative impacts on sperm parameters. And so cutting down on alcohol consumption, I would recommend stopping marijuana use if you're able to. And any lifestyle modifications that men make, it takes 3 months before we see an effect or improvements in sperm quality because of that. And that's because men's bodies are creating new sperm every 3 months. So any changes you make, we won't see that reflected until 3 months later.
Yeah, and the supplements for men, we talked about Proxy, but CVS and everyone has their own recipe, but it's primarily carnitine and antioxidants. I think that's a good thing, multivitamins. But we come back to good nutrition, which is, I think, important, and obviously avoiding other chemicals that go into your body. People ask about creams and other things that are on the skin. Relatively rare that would be a problem, but again, trying to eliminate chemical exposure is just good common sense when you get ready to be pregnant, for the man and for the woman.
Okay, good. Well, thank you for attending our webinar. Again, if you have further questions regarding any of the treatments we discussed, you may schedule with any of the physicians at SCRC, and we have several locations Beverly Hills, as well as Santa Barbara.
Wish everyone a good rest of the week, and again, we'd be very happy to ask any or answer any questions that you have. Consultations we do over the phone or Zoom. Thanks for attending.